We'll start in a few minutes. While we are waiting for folks to join us today, I would, if you could please quickly introduce yourself in the chat, the audience, and tell us your name, your organization of affiliation, and where you are joining from. So thank you very much. This is a message to the audience who is joining us today. Thank you so much for being here. While we are waiting for folks to join us for this webinar, if you could please quickly introduce yourself in the chat, put your name, your organization of affiliation, and where you are joining us from. Thank you. So we just give a few minutes to the audience to come into the Zoom room. We see already Jonathan is introducing himself. Thank you so much. He's joining from the Philippines. Welcome, Jonathan. That's wonderful to have you. I see also other attendees joining us. So feel free to put your name, your organization you're affiliated with, and your country where you are joining us from in the chat. This is Nadira. Thank you, Nadira, for joining us today. Wonderful to see you. A few people joining us as attendees. This is wonderful. Feel free as you join us to put the name, the organization that you're affiliated with, and the country that you're joining us from. Prita, thank you, from Pathfinder International. Welcome to Prita. So let's get started. Welcome everybody to our webinar series, Retail Drug Outlets in Low and Middle Income Countries, Unlocking Their Potential for Equitable Access to Quality Health Services. Today's webinar is the fourth of a series, and it's dedicated to financing pharmacy services. My name is Veronica Wirtz. I'm a professor at the Global Health Department at Boston University School of Public Health, and I'm filling in for Tamara Hafner, who unexpectedly needed to be out of office this week. A bit of background about the webinar series. USAID MTaPS goal is to enable low and middle income countries to strengthen their pharmaceutical systems to ensure sustainable and equitable access to and appropriate use of essential medicines and related services. MTaPS is implemented by a consortium of partners led by Management Sciences for Health, and my institution, Boston University, is honored to be one of the core members and core partners in this effort. So I work with MTaPS on this topic of today's seminar for quite several years now. Hence, MTaPS kindly invited me to step in for Tamara today. Any attempt to sustainably improve equitable access to quality pharmacy services must include strategic considerations of how effectively to leverage retail drug outlets, specifically pharmacies and drug shops. Why retail outlets? These outlets are often the first and the only point of contact for many health service users in many low and middle income countries. With that in mind, MTaPS is hosting a 5-part webinar series to explore the theme of advancing equitable access to quality pharmacy services through retail drug outlets. So the ultimate aim of the series is to help highlight existing policies and strategies that can be used as elements in defining the pathways to work with the private sector towards a common goal. Today's webinar is the fourth in this series, in which we will explore different financing models for pharmacy services and some of the financial incentives for engaging with the private sector to be good partners alongside the public sector in the provision of quality pharmacy services. As many of you know, financing is an essential element of any policy to provide equitable and quality access to essential medicines, including pharmaceutical services. However, countries, rich or poor, are challenged in ensuring equitable and sustainable financing for medicines. So with me today, I have a very esteemed and dynamic panel with whom I would like to discuss this topic. We have Jafari Liana, he's pharmaceutical advisor of the Apotheker Consultancy Tanzania. We have Neto Ikpeme, founder and CEO of Wella Health in Nigeria. We have Olumide Okonola, he's a senior health specialist of the World Bank Group in Nigeria. And we have Elizabeth Shikalak. She is the registrar of the Pharmacy Council in Tanzania. So I would like to welcome the panel. It's really a pleasure having you for this discussion today. And now we also have Lauren sharing the brief bios of all the speakers in the chat. You can read more about their backgrounds. So with that, what to expect in the next 85 minutes or so? We will start with a couple of basic questions, which will provide a foundation for our discussion. And then we will expand our discussion with the panel on opportunities and challenges in financing pharmacy services and retail drug outlets. And we will look at specific cases. We will look at the national health funds in Tanzania, and we will look at Wella Health, which is a microinsurance in Nigeria. And after 45 minutes or so of panel discussion, we will open it for questions from the audience. And for the last 10 minutes or so, then we will wrap up with a closeout by the panel. So a few quick tips for our audience. It's really a pleasure to have you. We want to have that as a conversation as much as possible. For that, we have a chat function. And we would like to ask you, as we go along in our conversation, please put your questions and comments in the chat. We will have a dedicated question and answer session, and where we take as much questions as we can. But throughout the discussion, we want also to see what you have to add to it. And please do so and add to the chat conversation that's going on. So let's get started with a foundational question to Olumide. Olumide, what is the burden of healthcare expenditure for individuals and households, particularly among poorer segments of the population? And how do medicines factor in here? Help us out laying this foundation for the discussion today.
Thank you, Veronica. I hope you can hear me loud and clear. It's a pleasure to be here. Please confirm you can hear me.
Yes, we can hear you, Olumide, and please go ahead.
All right, thank you very much. Your question is very pertinent because out-of-pocket expenditures for healthcare on the continent, at the moment, averages around 30%. And there's a whole lot of disparity within that average. If you consider countries like Botswana with 3%, South Africa 5%, and then you have some countries like Eswatini, Namibia in the region of 8 to 10%. Going all the way to countries like Sudan, my country, Nigeria, Cameroon, Equatorial Guinea, who are between 68 to 75% out of pocket, constituting, you can imagine having that high amount from total health expenditures. To even drive this point home, when these expenditures, when it's more than 10% of the total household income, or we use maybe it's more than 40% of non-food household consumption. This is termed catastrophic health expenditures. And why this is important is that it perpetuates poverty. Keeps people in poverty, and this cost is not just for medical consultations. In fact, medications constitute a big part of this. Sometimes almost 90% of the total cost expended on healthcare. And who are the people that are disproportionately affected by this high cost of care? They are the poor, vulnerable households, trying to treat basic illnesses from maternal, newborn, child, reproductive conditions, in the process of seeking care, they either forego essential treatment that they require, or go deeper into debt, or simply just resign to their fate, and the illness takes the better part of them. But the good thing is that governments are now beginning to pay attention, and within the construct of universal health coverage, which mostly is now the basis of health system reforms across many of our countries globally, the driving force behind a UHC reform is the role of public financing for healthcare. And that is a necessary, not sufficient, but it is a necessary condition to accelerate these reforms. Because where public financing is made available, especially for those who are unable to afford healthcare, then you begin to lay the foundation for taking people out of poverty and providing the necessary financial protection for them as they seek health care. I do hope in the course of the discussions, we can then dive deeper into some of those sufficient conditions that needs to be leveraged onto public financing, because the hood doesn't make the monk. You still need other reforms that needs to be associated with the availability of public financing. And I do hope that we can dwell into the bucket of reforms around what are the regulatory capacities in order to manage the pricing along the value chain, and what are the things that we can use to influence the behavior of the provider, and it's only when we look at all of these buckets of reforms in unison, what's a country doing in terms of UHC and health financing, what are the regulatory capacities, and how does it affect the pricing across the pharmaceutical value chain, and how do we hold providers accountable? And these are the kind of reforms we need to leverage to address these high out-of-pocket expenditures. Thank you.
Thank you very much for laying out this foundation for us. And let's now unpack some of the important things that you talked about, Olamide. And I would like to go to Jafari for a follow-up question on what Olamide already started to lay out for us and explain, which is this importance of the financial models that address the challenges with health expenditure, particularly when we see the high out-of-pocket expenditure. And Olamide pointed already out the important role that medicine play in that. So I wonder, Jeffrey, if you can speak a bit more about what are some of these financial models or other relevant policy responses government have pursued to help address the affordability gaps to enhance access to pharmacy service. Jafari. Jafari, can I ask you to unmute? At the moment, we can't hear you.
Thank you very much, Veronica, for inviting me to this session. And thank you, Olamide, for putting up the stage for the discussion to start and continue. Yes, out of pocket is a huge problem in developing countries. Figures have been provided by Olamide. There are several efforts happening in different governments to kind of assist the general public and the communities to address some of the challenges in affordability of medicines, particularly the out of pockets. Looking at some of the examples in Tanzania, so over time, the government has been providing some of the incentives or some of the models, policies, one of them being the exemptions. So Tanzania has an exemption policy for under 5, for pregnant mothers, for the elderly, at the age of 60 and above to receive free medical services in public health facilities. I think this is one of the really driving effort to support the poor, but also the groups that cannot really afford to meet the cost of out-of-pocket medicines. But there has been other efforts. Tanzania also embarks into the National Health Insurance Fund. This is a financing scheme, a national financing scheme, which also tends to group the risks for public employees, civil servants, but also private companies who contribute their salaries to the fund, about 6%, which is split into two. The government pays 3% and the employees pays 3%, and that's for the public sector. But for the private sector, the companies pays total 6. And this now covers the employees throughout the year. For public civil servants, it's mandatory. So once you're a public servant, you are automatically a member of National Health Insurance Fund, and 3% of your salary is deducted every month and contributes directly to your medical services. And that covers, National Health Insurance covers around 10% in Tanzania currently, but there are other models, the Community Health Fund, which takes about 25% of the general population. And basically, this is also another pooled risk, whereby members at the community level contribute a certain amount on a monthly basis, on annual basis, and that covers the essential medicines and essential health services to the communities. There are other efforts happening, but I will touch a little bit on the pharmacy services to the private sector. So we could, together with the National Health Insurance Fund, covering services to public service employees and other private companies, but they access services mainly through the public sector. But the National Health Insurance Fund went further to recognize or registered retail pharmacies, private pharmacies, and also retail drug outlets at the rural level to also provide services, particularly on medicines, especially when public health system is out of stock. So this is also another way of addressing the challenge at the community level, but using the private sector. Also through the Ministry of Health Policies and working with the Pharmacy Council, and Madam Elizabeth will talk more about that, formalizing and regulating the retail drug outlets at the community level was also another measure of ensuring that the out-of-pocket people who purchase medicines at the rural level also access quality medicines, but also in a regulated system, and probably by regulating the system has a contribution to improve the affordability, plus also the quality of the medicines. But also looking at the pharmacy, apart from the drug outlets at the rural level, looking at the pharmacies. So the ministry has had some policies of co-payment or subsidizing some of the public health products. We see clearly example for the National Malaria Control Program, which over almost 10 years now has been subsidizing availability of the first line anti-malarial treatment, artemether-lumefantrine, through the private sector in a co-payment model, whereby some funds from donors are set aside to procure some of these goods and distribute them through the private pharmacies, and retail prices are regulated for these products so that patients contribute or pay relatively less or a lot less than what they would have paid on a retail profit price.
This is very interesting. Mm-hmm.
Yes, there has been a lot of efforts happening.
Yes. And thank you for laying this out, particularly now from the Tanzania perspective. You talked about a variety of financial initiatives or financial schemes related to that. Let me bring in, before bringing Elizabeth in here to talk more about the role of retail, the retail sector in it, let me first go to Neto, maybe from the Nigeria perspective, if you could add perhaps a few other things from the Nigeria perspective when we talk about the financial incentives. Jafari laid out several things from the Tanzania perspective that exists in Tanzania, but I wonder, Neto, from the Nigerian perspective, anything to add in terms of that?
All right, thank you so much. I think here, really good background from Olumide and Jafari, and I would, concur with a lot of what they have said. From my point of view, and I guess to give some color and context to my perspective, is that I run Wella Health, and at Wella Health, we work with retail pharmacies to use them as a service point for fulfilling insurance claims, essentially. And we work with existing insurers so that they can send patients to pharmacies to get care rather than to the usual pathways that they do, clinics, hospitals, etc. And also we have our own microinsurance plans that we sell and service within the pharmacy network. And the motivation for this was what we saw around out-of-pocket payments, so absolutely huge problem. We did feel that the one way to approach that was helping to aggregate that demand, in that a lot of money is being spent out of pocket, but it is very unorganized. And we felt that having a microinsurance model tied to pharmacies where it's much more cost effective to service it would make a lot of sense. So that is where we come at it from. And so, certainly seeing the same types of things that I've been spoken about, and know that, retail drug outlets and pharmacies provide a really good opportunity for these basic illnesses in particular to be serviced. There is the financial incentive for them, of course, but there's also an affordability aspect for the customers, and also a convenience aspect that really aligns both the payer and the pharmacy. Thank you.
Great, Neto. Thank you again for bringing up another additional financing initiative, which are microfinancing. And we go into Wella Health in a bit and ask you more about how this is working at the moment, advantages and disadvantages. But before doing that, I would like to bring in Elizabeth now from the perspective of the Pharmacy Council, particularly asking you, Elizabeth, could you briefly describe the National Health Insurance Fund's relationship with retail drug outlets in Tanzania? To what extent do these retail outlets are integrated into the fund's benefits package as providers?
Thank you, Veronica and my colleagues, for the introductory remarks, and of course for the inviting me, Veronica, to this panel. What I can say is that National Health Insurance Fund and Pharmacy Council, both Ministry of Health agencies, so to speak, and of course the big role of the Pharmacy Council is to license these drug outlets and pharmacies, whereby after being licensed, the National Health Insurance again reaccredit some of these registered pharmacies and outlets for providing services, pharmacy services to members. As we all know, of course, Olumide has just mentioned regarding the health expenditure. We understand that the government budget has never been enough, and of course we know that the government is responsible to provide for all services to its citizens. But again, these drug outlets do complement what the government is lacking, because the NHIF introduced this accreditation system to the pharmacy and drug outlets not recently, but more than 10 years ago, after realizing that the government cannot provide in fully. So these pharmacy and medical stores or medical shops do receive accreditation from NHIF to provide for the services, as I said. And of course, there are limitations because the National Health Insurance Fund has got its own health benefit package. And because of the affordability issue, you find that most of the medicine that is supposed to be purchased are those generics, which the government can afford to reimburse, compared to other schemes where there is no limitation, you can get the branded product and so forth. Because entirely, as Jafari has mentioned, is that NHIF mainly is for the public servants, public service employees. So there is issue of health benefit package. However, sometimes even myself, I have two insurance schemes. I'm getting NHIF because it's mandatory and it's directly deducted from my salary, but I also look at the other health scheme because I can access more services than what the NHIF is providing. So it is also similar to drugs. The problem with us, we as clients, we have choice. So what I can say, the health benefit package which the NHIF provide also has got the pricing. And sometimes even in the retail shops, some of them are not interested to join the NHIF because of the pricing issue, because that issue, it is set in a catalog, I think, for a minimum of, if not 3-5 years. So sometimes the price can go high, and these people, they say, no, we cannot work on the loss. So this is how the things are playing around here. But again, if you look at the retail pharmacies that
yes, go ahead. We just lost a little of your audio. Please go ahead. Now we have you back.
Oh, sorry about it. So what I was saying that today NHIF has accredited around 868 outlets to offer for these services, compared to 2,690 pharmacies that has been registered vis-a-vis 14,900 around the adult, this small shop. So you can see the number is very minimal. And 2 weeks ago, if not 1 month ago, we have suspended it for a while because we need to do some evaluation to see, because this was initiated because of the out of stock, of course. But we said, okay, as the government, are these retail shop, apart from the public-private partnership, have they contributed to the strengthening of pharmacy services in the public sector or not? So we are now in the process of doing an evaluation to see, but we can still underscore the role of the retail drug outlets to cater for health services in Tanzania.
And you have spoken about the regulation of prices. I see just a nice question related to that from Anindinda in the chat. You have spoken about this regulation that is from the National Health Insurance Fund regulating prices, but you have also told us, Elizabeth, that not every pharmacy necessarily want to participate in that scheme because of the price regulation, saying if prices fluctuate and if we set these prices for 3 to 5 years, and if the pharmacy then needs to pay higher prices to acquire the medicines, that will obviously impact their profit margin. So it's very, very interesting perspective, Elizabeth, particularly also now the latest developments that you're talking about and saying, wait a minute, we need to press a pause button and evaluate some of the things that have been going on to learn more. Jafari, can I ask you a follow-up question about the National Health Insurance Funds and help us understand what is the client profile of the National Health Insurance Fund? Elizabeth talked already a little bit about herself and what are kind of the health insurances that she uses, but how does this client profile compare to other health insurances? And tell us more about the affordability of the benefit packages. Have you any evidence that they actually enhance equity, particularly for poorer segments of the population. Jafari.
Thanks, Veronica, for follow-up questions to the good information that Madam Elizabeth has provided regarding the NHIF. And as we said, currently the evaluation is going on. So let's cross our fingers that the evaluation comes out good. And so the services continues. So to speak a little bit about the NHIF packages and whether they are affordable or not. So let me just reiterate that about of the members of NHIF, about 67% are public employees. So the remaining percentages cover private companies, but also individuals and families. So how do individuals and families come in? So over a period of years recently, NHIF expanded its services to actually private and individuals, members of the community, with different packages for different fees that they charge, and also their reimbursement, the services that they pay. So there are about 10 different packages that they offer. For the public employees, I think it's just one package where once you've contributed your salary, regardless of the size of the salary, you receive the same types of services. But for the families, now the packages ranges from an individual person package, a family package where a family of 1 child, 2 children, 3 up to 4. But also there are packages of specific groups, like, you know, truck drivers have their own association and a group. Motorbike drivers have their association, they have some specific packages there. But also there are some interesting packages for children under age of 18. So they also have a specific package for them. But also, and this is for the families who are, you know, parents are not employees of the government, so they are not on the main package of the civil servants. So families, if you have a child under 18 years of old, you can pay to NHIF and it is covered throughout the year. But also they have packages for students, college students who are now above 18 years, who are not employed yet, but they're still in the college. So they also have a package. Now, these two packages, the students and once you've been a member enrolled under a certain package, so you receive the benefits, and the benefits cover medicines, as Madam Elizabeth said, basically essential medicines, investigations and diagnostics, the basic ones, consultation by physicians and prescribers, but also dental services, eye services, deliveries, some special services of higher level, like medicines, which are relatively expensive, or diagnostics, CT scans, MRIs. So those ones are retained to this higher level packages, but for the basic packages, you receive these other basic services. So I'll give an example of the costs for the packages to see whether they're affordable. So I'll start with the children, and the students pay is around $25 a year. And to me, I would consider this is affordable, because $25 can just be a one consultation, one cost of treatment per sickness episode. But if your child pays $25 a year, then she's covered, he or she is covered throughout the year for medical treatments. So these two packages, I would consider them to be affordable packages. The other ones, the individuals and the families, they range from $180 to almost $800, depending on the size of the family and the size of the package you are taking. And these ones may not necessarily be affordable to the common Tanzanians, particularly those in the rurals, or even the poor in the urbans. But actually they were meant to complement another effort of the government, which is the Community Health Fund. So where the communities cannot afford NHIF services, there is another funding system, insurance scheme, which is the Community Health Fund, and which has relatively lower rates, but also lower services. But this is the one that can be affordable for majority of the population. So to answer your question, whether the packages are affordable, some of the NHIF packages, especially the children, the students, these are affordable, but some of the individual packages may not necessarily be affordable to the common Tanzanian at the rural community level. For the government employees, civil servants, that's deducted from the salary, so there's no choice whether you want to be in or out, so you are almost covered.
I want to bring
I'm not sure if that answers your question.
Yeah, absolutely. And this is very nice how you laid it out, and you talked about the different packages, the different target groups for these packages. And I want to bring in now Olumide for a follow-up question about something very important that we spoke about now in terms of the equity dimension of it and affordability, particularly in terms of the medicines. Can you talk us through a bit from a regional perspective, now talking about different insurance initiatives, and Jafari and Elizabeth talked about these different insurance initiatives in their kind of like context, Tanzania. How does this insurance scheme compare to other national insurance schemes in the region? Can you give us a perspective on the evidence on equity? You spoke in the beginning on the impact of medicines and household expenditure and on the financial side and the catastrophic impact of medicine expenditure. What do we know about these insurance schemes, and in particular related to medicines, and what they have achieved in protecting households from catastrophic expenditure?
Thank you, Veronica. First, let's perhaps unpack this aspiration towards universal health coverage using the vehicle of national health insurance programs, either at a national level or at a state level. In decentralized contexts like Nigeria, you have these insurance programs at the state level, and they are as large as some countries, you know. So there are some things that we know about these insurance schemes, which is all well known to everyone. The larger they are, the more diverse they are, and the better they are able to spread risk. And again, part of a commonality is that because it's a social protection kind of platform, like I mentioned earlier, public financing is important to bring in those who are unable to afford care into those pools. So there's a need to understand that the financing source that brings in a particular beneficiary into the pool is almost irrelevant. It's important, we know it's from public, whether the person is in the formal sector. The important thing is that financing gives this person access to this pool. And the big point from that is, ideally, you would expect all beneficiaries to enjoy the same benefit package. And all of these have implications for access to pharmaceuticals down the line. Because if these pools are fragmented, it then means that you would have a smaller sizes. One direct immediate implication is that the power of the authorities running that pool will not be as significant in terms of negotiating prices. So imagine if you have one country, one benefit package that is so huge, the kind of monosonic power that that entity has in terms of deciding prices. So, but all of this, I think, mostly in the realm of health financing reforms, which maybe we shouldn't dwell so much on that now, but it shows that, and by the way, this we find across several countries in the region, where because you have formal sector participants who are directly contributing to the scheme, they have their own benefit package, probably more generous, even expanded. You have the poor and vulnerable, largely from public finance subsidized. They have probably slightly smaller benefit package, so, and yes, several countries have also recognized the need to begin to integrate so that the pools can get bigger, and then they can begin to mention some of the things that I would now highlight. So the essence of having these entities, by the way, is to be able to mediate what broadly we call strategic purchasing functions, where there is a defined benefit package. You have providers who are, because they've met a certain quality criteria, they are empaneled into the program. And I think Elizabeth, alluded to how retail outlets and pharmaceuticals are also empaneled. So the empanelment criteria goes from clinics, hospitals, to retail and pharmaceutical outlets. And lastly, how are those providers paid? So I'm laying all of this out because you might have an entity called an insurance fund or an insurance scheme, an insurance program. If all of these things are not in play, then we will not be able to enjoy the benefit from strategic purchasing. And just to close out on this, it has a knock-on effect on pharmaceutical pricing because the agency now, one, is able to have standard treatment guidelines. Based on its standard treatment guidelines, it has all those protocols with certain medicines. The power that entity has is when you deliver care to a beneficiary in the scheme, that entity has the power to either reimburse or not reimburse. If you treat, for instance, with a branded medication, and that's not in the standard treatment guideline, I will not reimburse you. So I'm really driving straight home to things like, so you have things like the essential medicines list becoming now important because of the kind of financial incentives and the kind of power that these entities wield. And because they have such a huge number of beneficiaries in their pool, they are able to dictate how the pricing should be. They are able to also influence prescription behavior. They're able to hold provider accountable. So there's several ingredients there that I believe these new health insurance funds or schemes are able to make medicines affordable for the poor and vulnerable.
Thank you very much, Olamide. What I like specifically how you lay out this kind of system perspective that you say has a trickle effect on, let's say, the provision of medicines, the specific quality then of the pharmacy services, by really taking us through the different conditions that you need to ensure, and insurances obviously have a critical role on creating such conditions. You talked about treatment guidelines, you talked about the selection mechanisms for these medicines, and then finally also provider accreditation. We talked about this. Elizabeth talked us through an example in Tanzania, how that works. Let me now bring in, so we talked about national health insurance. Let me now bring in a model that Neto has pursued with something called the microinsurance. Neto, talk us through what is the difference between a national health insurance now, like your micro insurance, what is it, and how does this address access to medicines and quality pharmacy services? Where does this come in?
Yeah, thank you so much, Veronica. So it's excellent to hear, the thoughts that have been shared, because that is what we're seeing in practice. So for us, because we know how much people are paying already out of pocket for healthcare, and the difficulty with getting health insurance, public health insurance schemes to people. So we've innovated to create a model where we can distribute really affordable plans. So our plans start at around $1 a month. Now they only cover a small basket of conditions, but they are conditions that people would kind of experience on a day-to-day basis. And so it really meets the need that they have. That helps with building trust, because people don't like the idea of, putting money away that they're not sure they will use. So we say to them, well, you're more likely to use this because, for instance, you're probably going to get malaria sometime later in the year. How about you put some money away in essence for it? So we're able to, bridge some of those gaps around understanding what insurance is, how it works, trust, and of course, affordability. So we introduce them to this idea of insurance, and then they can start to increase their benefit package. So even though we start at $1 a month, you can actually progress on to getting plans that provide a lot more once you've built that trust and you now understand what insurance is like. And so as we've built out that pool, we are now finding that, because like I said, the primary channel via which we service a lot of these claims is pharmacies, is that we're actually starting to funnel a lot of claims and patients to pharmacies. In some instances, we provide up to say 30 to 40% of the revenue that pharmacies see. And as Olumide alluded to the idea of the monopsony, we are in some instances beginning to be a large purchaser. So it means that we can now force those pharmacies to act in a certain way. Now there is an alignment between the quality of care that they provide and how they make profit. So that in instances where pharmacies err and don't live up to the standards that we prescribe, we kick them off the platform, and that they really suffer as a result of that. And so for you to stay on the platform as a pharmacist, you have to sign on to our own terms. We provide training, actually. We provide a simple protocol for the conditions that we have. We provide some support. And so we're starting to see really improved quality of care, because we are essentially a large purchaser that the pharmacies themselves have to keep happy. So we're starting to see this on a small scale, and our hope is to grow it extensively so we grow the power that we have.
Neto, that is really interesting, and thanks for taking us through the approach that you have taken and small successes that you have seen. I wonder if you could elaborate a little bit more on what you just mentioned in terms of the improvement of quality, or the strive for ensuring certain quality. And this is related to a question I just see in the chat that Preeta is asking. She's asking in terms of how do we ensure that quality? You spoke about the specific aspect. You spoke about that when a pharmacy retail outlet does not adhere to certain quality standards, it will not be continue to be impaneled, with using the term that Ole might use, not be part of your outlets that you are relying on. How do you audit them? How do you surveillance quality? Take us through how does this work, and how is it then made sure that you have really a grasp on what the quality of services are that are delivered in these outlets?
Yeah, thanks for that. So we have a 5-point rating scale, actually, that takes into account a variety of things. First of all, obviously, the satisfaction. So the patient or the customer has to be satisfied. So where they are not, we take that up seriously with the pharmacy. We would, go back to them and ensure that they're able to fix those challenges. So some of it is around customer service. For instance, it might be, an attendant was rude to me, which happens quite a fair bit in the markets we're in, and people don't like that. So, simple things like just customer service, we try to work with them to improve that. Also, in the quality of medicines, we ensure that we actually audit their supply chain. In some instances, we connect them to suppliers, and we ensure that the medicines that they supply have a mobile authentication system on them, so that when customers get it, they can scratch off that panel, send a code, and to ensure that it's authentic. So auditing the supply chain and making sure they have an authentication system on the medications. Beyond that as well, we do some things around payments. So we do a lot of electronic payments. We ensure that, there isn't any fraud around that we're able to, confirm pricing and things like that. But essentially within that 5-point scale, we're able to arrive at an average score for each pharmacy that tells us when to intervene, and when pharmacies aren't keeping that score up, we unempanel them, if you like. So that really keeps them in check. And like I said, as they're starting to become more significant as a source of revenue, more pharmacies are making sure that they keep us happy.
Mm-hmm. Do you involve also pharmacy associations in this work of auditing? And if so, take us through what is the role of any pharmacy association, pharmaceutical councils in maybe auditing or surveillance or setting quality standards? How do they come in?
Yes, so a central partner for us in Nigeria is the Association of Community Pharmacists of Nigeria. So we actually work with pharmacies that are part of that association. So we have a symbiotic relationship there where they introduce us to pharmacies, and then we make sure that those pharmacies that we work with are a member of that association. So quite a good partnership there. Also with Pharmacists Council of Nigeria, we ensure that they are all registered, and if they are not, we are able to actually put a process in place that helps them to meet the standards of the Pharmacists Council of Nigeria. So work with those bodies to ensure that that happens in Nigeria, yes.
One interesting question that came up in the chat, and I see already Jafari and others contributing, which is wonderful, is the cost of transportation. So Neto, when we talk about the incentives, the financial incentives of pharmacies to get on board, to be attracted by your scheme, can you talk us through in terms of what goes into the product price and how does transportation figure into that, particularly in rural areas that has always been come up as a very contentious issue?
Yeah, so at the moment, honestly, we're really focused on urban and semi-urban areas. So I don't have a lot of practical experience on the rural side because yes, it is challenging. The advantage of retail pharmacies is they've already figured out how to get the products into their retail space, right? So as long as we audit the chain and we're happy with it, we persist with what they've already figured out. Where we find is most helpful for a lot of retailers is that they're able to actually predict demand. A lot of the waste comes from pharmacists not being able to know, how many packs of anti-malaria, for instance, do I need to keep in any 1 month? A lot of times it's guesswork. There's no data. There's no place for them to say, you know what, I can be assured I'll get, say, 10 patients from that source. Again, we provide them with a little bit more stability, a little bit more ability to predict demand and to plan appropriately. Because on our chronic side, we do a lot of chronic business as well. We could actually, a month ahead, tell a pharmacist, well, you need to keep, 10 packets of metformin in stock, for instance, because we know we've got 10 people that need metformin in your location, we'll send to you. So that really helps with, reducing wastage, helping them to plan stocks and inventory. And that also helps with them, having more profit. So the data and the aggregation really helps both sides of the marketplace.
Mm-hmm, mm-hmm.
Yeah.
Very, very important, Neto, and your examples obviously really contribute to that discussion. Let me bring in Elizabeth again. And Elizabeth, you talked about the very important change that has happened recently in Tanzania in your context, in which the contract with retail pharmacies and the work with retail drug outlets has been put on pause of evaluation and looking at the scheme in the light of what now Neto commented in terms of what are the financial incentives of pharmacies to get on board. What are the long-term strategies to provide quality services, but at the same time provide business incentives? Elizabeth, can you talk us through what do you see important in continuing a successful relationship between the public sector and larger insurance schemes with retail outlets?
Thank you, Veronica, for, I can say, a very tricky question, but what I can say is that, of course, the initiative that is going on now, not because we want to stop them, but rather we need to see how the NHIF can engage with the private sector in a more efficient manner, in the sense that, of course, there are some challenges, as Olomide mentioned, that sometimes we fail to reimburse these pharmacies due to number of factors, but the fraud also is there. But there is issue of pricing and overprescribing and things like that. So maybe my view could be, I know once we have done with whatever evaluation which is happening now, we could come with the more efficient system whereby there will be more control, so that we cannot deny people getting pharmacy services. But also because the government is also preparing to go for the universal social health insurance, maybe we want also to see how the government is going to embark on that, because we need to have funding somewhere to complement with that. And in a few months, we are going for the national census, so that we really have a new data. How many are we now in Tanzania, so that we can have proper planning also in health expenditures. So I cannot talk more about it, but rather I still insist that despite challenges that has been happening in running this system through the pharmacy and medicine outlets, but I'm sure it will come with a positive results and make us move to the next level. But looking at the pharmacy also, maybe it will be the same in Nigeria. Unfortunately, most of the pharmacies, leave alone the small shops. Pharmacies in Tanzania are situated in major cities, and you find that a majority of the population live in rural areas. I can say 80%. And that's where now that's where now the initiative of improving access to medicine in rural areas came in, because we realized that people do face challenges in accessing some of the essential medicine. So that one also, I think, will be addressed to see, because even in the medicine shop, there is a limitation of availability of medicine there. So we want to see it to get a bigger picture, and how are we going to control. I've seen there are also a challenge of issue of pricing. So I think through that, once the government is taking everything on board, I think the issue also of pricing will come. But recently we have developed a regulation for pricing. But again, the challenge comes, Tanzania do import all the pharmaceuticals, most of the pharmaceuticals, I can say 80%. So we know there is a transportation cost and all that. Who is going to bear that? So we also embark on promoting the local production of pharmaceuticals, because I think that's also a sustainable way to look at we can control the price once we know exactly what it costs. But for the imported pharmaceuticals, sometimes it's a challenge because they are coming from different places. So maybe that's what I can say for now.
Thank you very much, Elizabeth. Before we go to two questions that have been put in the chat for NATO, I would like to ask Jafari to comment on an aspect that came up in Elizabeth's explanation, which is related to prices, and again to the business initiative incentives for retail drug outlets to get on board. And this has to do with the level of prices and what goes into the prices of products, which is including transportation costs. And you put something interesting in the chat about initiatives to think more about supply chain and distribution costs and wholesalers, particularly for the distribution of products into the rural areas. Can you talk us through, Jafari, what kind of initiatives have been discussed and how have they been implemented? Have they been successful? Talk us through a bit about this issue of transportation costs and how they factor into the product costs in Tanzania.
Thank you, Veronica. Yes, the transportation issue is an interesting subject. The countries, some of our countries are huge. Tanzania is a 1 million square kilometers country. The park of Serengeti itself is the size of Belgium. So when you're actually talking about transporting medicines to different parts of the countries where the retail pharmacies and the rural drug shops can access these medicines, that becomes a challenge. There has not been any kind of harmonized system that brings down the cost of transportation. But over time, things that we've seen, which have been evolving naturally, is as the businesses expand, we see the suppliers moving away from the major cities into the regions so they can get closer to the retailers and improve their presence and also improve their distribution system. And that has a contribution in cutting down the prices. But something very natural that we have seen in Tanzania, I've been here in the past 10 years moving around the country, is the improvement of the road network in the country. Tanzania has 26 regions, which are now all connected through tarmac roads. And therefore, the recent assessment that I was conducting in relation to transportation of medicines, so medicines can now move from Dar es Salaam, which is in the center of the country, to the northern 1,000 kilometers and to the southern 1,000 kilometers in 24 hours. So if a truck leaves Dar es Salaam late in the evening, it arrives in Mwanza the next day in the evening. So we actually see where transportation used to take 3 to 4 days to get the goods out there, which had a big contribution in terms of cost, but also quality of the products. Transporting goods through rough roads takes a lot of time, and therefore medicines undergo damages, but also the transportation cost is high. So over 10 years, we've seen a significant reduction in terms of cost of transportation of medicines from the central importation area and distribution to the regional level because of the natural improvement in the government efforts to improve the road networks. So there has been a development in that area, but still, as far as you reach fight in the rural, still there are other ways that need to get the medicines to where the retail drug outlets are there and cut down the, and that also has a contribution in terms of putting the price down. Pharmacy Council has done a tremendous job in terms of advocating for wholesalers and suppliers to move out of the major cities, but also creating another opportunity for small drug shops to create the so-called restricted wholesalers. So these are small wholesalers who supplies to the small drug shops with a limited list of medicines, and therefore they can establish their presence at the rural level where most of the drug shops are. So those are some of the dynamics which are taking place in Tanzania to improve the supply chain.
Thank you very much, Jafari. And these are obviously positive and encouraging developments, particularly when it comes to prices and the component of transportation costs that factor in, and how now, let's say, also wholesalers and distributors contribute to, let's say, lowering transportation costs, and certainly also opportunities for policymakers to think about policies in incentivizing, let's say, the provision of affordable medicines that can be made available in retail outlets. Neto, can I ask you to follow up on some of the interesting questions that have been put in the chat before we hand it over to Olamide for some other questions related to the regional picture? But Neto, I see some questions in the chat on how has your engaging with pharmacies helped in providing more access to quality healthcare in Nigeria, as one question in the chat, and another is it only the legal registered retail pharmacies that benefit from the microinsurance, or do you have a case of other outlets also accessing these services, particularly here in reference to what is called illegal outlets existing in Nigeria? And Neto.
Yes, thanks. So regarding access, I mean, pharmacies they're just a lot more convenient. What you often find is when you go to a clinic, there's a wait time. You have to wait to see a doctor. There's a process. You've got to, open up a card, get this and that done. So it's inconvenience. People don't like it. It's also expensive, especially out of pocket. Pharmacies, there's more of them around. The wait times are a lot less. It's just more convenient, and of course, it's less expensive. So that is increasing access. There's also more of them around, and it's closer to where people live. And so leveraging them has really transformed access, because people can just go there and know that they'll get quality care because we have a stamp there, and it's more affordable because of the microinsurance bit that we lay on top of it. So we think it's transformational. In fact, I believe, I'm a physician myself, I've trained in medicine practice for a decade now. I believe that the future of health across not just Africa, a lot of the world is actually based in pharmacies. Pharmacists and pharmacists can do a lot in communities to provide really high quality primary care, supported of course by technology and remote physicians. So that's a belief that I have, and we're really pursuing it. With regards to the type of pharmacies that we work with, it is only legally registered pharmacies, because yes, I think they do need that training, they do need that support, they do need that oversight from the regulator. So we only work with legally registered pharmacies at the moment. I think especially when you're looking at going further into lower income people closer to the base of the pyramid, people in rural areas, we've got to figure out a model where we can work with, in Nigeria, call them patent medicine vendors. So, not quite, sophisticated as pharmacies, but they do provide some service. So understanding how we can help them be better regulated and provide better quality, I think is something to figure out in the future. And there was one question about the number of claims or proportion of claims fulfilled by our scheme. I'm not sure what the denominator for that question is, but for the plans that we sell, we actually fulfill essentially 100% of those claims. And that is the benefit of our model. It's tightly integrated with the plans that we sell. They can come into any one of the 1,700 pharmacies in the network to have care delivered to them without paying any cash at the point of care.
Excellent, Aneto. I think also thank you for pointing out, let's say, some of the challenges. How can we ensure that in certain areas where you might not have sufficient number of registered pharmacies yet, how can you expand your services to those? Perhaps there is, as you say, a middle ground with negotiating certain basic services being in place without these pharmacies, maybe to go through an elaborate, let's say, accreditation, which might not be feasible for such businesses and small businesses. But I think definitely an important point for the discuss. Olamide, I see you have also some comments now to add to our discussion, and I wonder particularly to setting prices and providing on one side business incentives, but on the other side making these schemes sustainable long term. Olamide.
Thank you very much. I'll just take one step back and very quickly highlight some terms that we've been using a lot within the paradigm of universal health coverage, and that is strategic purchasing. What did just drop from the sky? Being strategic means you have activist policymakers, both in the insurance fund, both in the pharmacy control agency, or whatever name we call them, who are actively, checking what providers are doing, actively looking at prices, actively looking at the outcomes, along using information, like Neto said, in terms of ICT. That's a whole spectrum of strategic purchasing. Again, how does that come into play here? There are few things that needs to be in play, because if we don't fulfill those sufficient conditions, several of the things we're talking here might not necessarily happen. So there's value to be extracted from prices. So for instance, you can extract value at the level of the manufacturer. You can extract value from the distribution component, and you can extract value at the retail and dispersing level. If you do not have activist policymakers, both in the insurance fund and in the pharmaceutical regulatory agency, to say, look, on the essential medicines list, you've agreed on a defined pricing, and then you are able to say, look, for those who are able to take these drugs perhaps on the essential medicine list, to the farthest point, this is what you get. If you do not have such explicit arrangements in place, Veronica, I'm sorry, but most of the things we'll be discussing here would just be poetry. So we need the likes of Elizabeth, to sit down with the insurance fund and say, at least starting, but look, if we're able across the continent to start with the essential medicines list, manufacturers they care about returns. And this is the way to guarantee a market. And you're able to say, because right now, the kind of margins that retailers are making is huge, but they can even make a whole lot more at a lesser margin, because there is an untapped market in our rural areas that are currently underserved. But when you have a guaranteed payer, like the insurance fund, who say, look, provide, I will reimburse. But then you are able to first guarantee that, look, this is where the margin lies. The second point is there's a need to begin to look for alternative models. What Neto, where, for instance, very quickly in terms of health insurance broadly, we have a problem in health insurance called the missing middle. In universal health coverage context, like I mentioned, the poor and vulnerable usually covered by through public financing. Those in the formal sector usually contribute from their salaries or income, but for a significant part of the population that's in the informal sector, we don't even know who they are, but they are not necessarily poor. And I see the likes of NATO very able to tap into that market with the kind of innovative arrangements that they're bringing to play, because even the fact that you have a mandatory provision does not necessarily mean that people will sign up. We are not even able to tax them for other things, but that's on the health insurance side. That kind of thinking needs to come to availability of medicines as well. Because we're talking retail outlet does not mean that it needs to be physical. It could be virtual. But all of those would mean that the regulators, the insurance funds, the pharmaceutical agencies, they've been able to create the enabling environment, including the government, the budget office, the Ministry of Finance, like Elizabeth mentioned, most governments across the continent are trying to protect the local industry. So no taxations for drugs manufactured locally. It doesn't necessarily mean that it's cheaper. Maybe you're now taxing drugs imported from overseas like India. I know in Tanzania, in fact, Elizabeth mentioned it, almost 90% of the drugs come from India. But then the transaction cost in India could be, in Tanzania, could be higher. At the end of the day, the fund or the beneficiary will be the person to bear the brunt. So look, there's not one solution. It is a bouquet of policy options that activist policymakers like Elizabeth and NAFDAC in Nigeria and insurance funds, they need to sit down. I must say that across the continent, these regulators are not necessarily sitting down together as much as they should. I must say that because, and we need them to do that because that's the only way we can have the kind of change we desire. Back to you, Veronica.
Thank you very much, Olamide. I'm smiling because obviously many of the things that you mentioned, you tie together, you kind of bring them together in a more system approach. And I like this very much because it hits on a lot of the points that we have discussed. And you point us to the interaction and the interreliance on some of the things. So saying if you have one thing not in place, don't wonder if the second thing that you're hoping to achieve doesn't occur. You need to create what you call this enabling environment. And this has to do with many of the aspects, and not only the policies, but also you need to create a market environment which is even more complex in some of the aspects we talked about, such as local production versus importation and questions around that, and what does it mean for prices given the tax environment in which we are, and other factors that the context is dictating. I would like, I'm looking at the time now, I see that we have answered many questions in the chat, but I think it would be now very timely to ask each of the panelists for commenting on the enabling environment and the most important factors for that Ole might laid out. And I would like to start with you, Elizabeth, maybe as a direct response to some of the things that Ole might mentioned. From your perspective, what are the most promising policies and strategies that we should think about if we want to think about sustainable financing of medicine benefit packages in relation to retail outlets providing part of those benefit packages and are part and parcel of the providers of those packages. So starting with you, Elizabeth.
Thank you very much. I wasn't expected to be the first one anyway, but what I can say, I heard Olomide very, very clearly, and what I can say, of course, all this came around because retail pharmacies need to complement what the government should provide. And of course, to me, I would say that the government has to increase its budget, its health budget from where it is. I think now it has been decreasing. I see this year, if not mistaken, it has been decreased by 1 or 2%. So once we are decreasing, of course, much as it is not enough, we really need to increase the budget so that we can reduce the burden for the out-of-pocket clients, so that at least once it is increased, the retail shops can also be provided with the incentives in terms of the pricing, because what I'm seeing is that sometimes we don't reimburse because it is too much for us. Even the National Health Insurance Fund is trying to protect itself because billions of reimbursement sometimes has to happen, but as the fund has no enough, the funds is not enough. So they are trying to cut here and there. So maybe that one comes because in the government, we have not been able to provide enough. So increasing the budget, that could be my suggestion. The increasing of the health budget might be. Olomide commented about of course, I know even the local production, it cannot be a permanent solution. But what we see even here, the one which are imported actually are cheaper than the one which they are locally produced. But people trying to compare and make decision out of that. Okay, we need to promote these people. Let us buy in whichever price they are giving us, because we want something which has been produced in-house, domestically. Of course, the issue of there are a lot of issues when you take medicine from outside, I would say, because sometimes there are hidden costs which we cannot see directly, because for us, in order to register one product, you have to pay around 3,000 USD. And that factory needs to be inspected for 5,000 USD. So my mind or my thinking could be, maybe if this cost could not be there, probably even the imported drugs could be more cheaper comparatively. So my take home message that maybe our countries, not only Tanzania, but the other countries in the continent should think of increasing the health budget to cater for the health services.
Absolutely critical. Obviously, when we talk about financing, what is the budget to begin with that we need to have available for the services that we want to offer, and that is an important, I would say, a very, very important point that you raise, Elizabeth. May I now move to Jafari, and Jafari, from your perspective, complementing what Elizabeth said, in terms from your perspective, what are the critical things to create that enabling environment that Olamide talked about? What else do you think is still missing and needs to be considered?
Veronica, thank you.
Sorry, Jafari, it just hit mute now. If you could unmute.
Correct, thank you. Yes, thank you so much. I think the two speakers, Olumide and Elizabeth, have spoken very precisely. My little comment to add what needs to be done to contribute in the private retail drug outlets to ensure that they make their services affordable. Number one is, I think there is one element that we are missing across many countries is availability of data from private sector supply chain. We oftentimes see data from the importation level, but what happens down in the private sector, it's not known. So much of the attention is not given to the private sector supply system because not much is known. That is available in the public sector distribution system, but private sector majority of us don't know what's happening. So we need to make this data available to make the decisions more informed. Number two, private drug outlets needs to be assured of their business, need to be assured with the clients. And Olumide has spoken very well. If we have our systems harmonized up there and then have powers to negotiate prices, have powers to incorporate the different retailers, negotiate the prices that they can provide the services to, the retail drug outlets are ready to lower down the cost. They just need to be assured of the market and the business that they can do to the client. Currently, everyone is struggling on his own, and the easiest thing to do is to rise up the prices. But if systems are harmonized and they know that the insurance schemes or this reimbursement schemes give them business, then they are ready to cut down the cost. We saw from NHIF at the beginning, when they were starting the fund, inviting retailers, people were hesitant to go in. But later on, when they saw that there is an assurance of customers with the, of course, reduced prices, but increased volume of customers, then people are rushing in to join NHIF. So we just need systems to get harmonized so that retailers can be assured of the clients. My last comment would be, in developing countries, retail pharmacies and drug shops is an integral part, a major integral part of service provision in pharmaceuticals at the rural level, because this is where majority of our people lives. Pharmacies alone cannot go everywhere. Public sector cannot serve everyone. Drug shops, small drug shops really meet the needs of the people. So they need to be regulated. They need to be brought into the system. And so to ensure that the services they provide are of good quality and the prices are somehow affordable. So that's my take for today.
Thank you very much, Jafari. I like a lot your point, particularly on harmonized systems and the assurance of that there are clients that private outlets can have as one important part of their business, and the emphasis that you give on the critical role that outlets play in health systems, particularly in rural parts, and it is really critical, therefore, to bring them in and have them as part of the delivery mechanisms alongside the public sector, and this requires affordable prices. Neto, can I ask you from your perspective, what are the critical elements to create an enabling environment as Olamide has laid out?
Thanks so much, Veronica. I think I'll re-echo what the others have said. I really subscribe to the thoughts and ideas there. I would say that from my point of view, working with over 1,000 retail pharmacies, is that I think sometimes, certainly from the Nigerian experience, and this may or may not apply in other African markets, there isn't enough recognition on the public side that the private sector and market is really important to scaling access and affordability. I think that sometimes there's a disconnect between the reality of the fiscal space that governments have and the policies they enact with regards to how they want to deliver healthcare. I mean, we know that there aren't enough public facilities, for instance, and so if you're going to increase the pool, then you would have to obviously work with the private providers. So really, for governments and public policymakers to really internalize that, and then to create models that really bring the private providers in. Of course, there's always going to be challenges around pricing medications appropriately, but as Jafari said, as volumes come in, then people are more likely to be flexible there. But perhaps, can we explore allowing people to have co-pays, for instance, in the initial phase around, say, certain particular medications or certain things, so that, especially for people in the middle, like Olumide alluded to, they are happy to pay a premium and perhaps pay a co-pay at the point of care to access, some type of a premium benefit that then that pharmacy can enable. And also, I think that there is an opportunity for the pharmacies and retail drug outlets to serve as distribution partners, to build trust, educate people, and to actually sell these, insurance plans and the types of benefits and plans that, the government and others want to do. So I think that those opportunities exist, and the public policymakers should leverage them a little bit more. Thank you.
Thank you, Neto. Olamide, can I ask you for a few closing remarks from your perspective?
Thank you. Yes, so just to say that we have most of our countries just emerging from the pandemic, but then we see another challenge creeping into the fiscal situation, which for the war in Ukraine, for instance, is predicted to push for an additional 1 million Nigerians into poverty. And we're probably going to see that across the continent. And this makes a strong rationale for our policymakers to engage with ministries of finance and budget to say that, look, this is not the time to wind down the kind of support that the sector got during the pandemic. And we need to be able to make our case in a very strong manner. And this is just to build on what Elizabeth has said in terms of increasing public financing for healthcare, because as I said, this is a necessary condition for universal health coverage. But we need to be able to make our case in a way that is strong, and also to be able to show that we're able to provide value for money. A very quick point is usually when beneficiaries are identified, we don't normally leverage other pro-poor programs that the same government is supporting. So one quick nexus there is to try and leverage other pro-poor countries. Also to mention, there's a need to engage with the Ministry of Finance in terms of macro fiscal reforms as it relates to pharmaceuticals, because I can recall the Healthcare Federation of Nigeria at the height of the pandemic wrote really a strong letter to the Minister of Finance asking for waivers, asking for reduction in tariffs and all of that. All of this is aimed to reducing or making the prices of drugs more affordable, and you need data to do this. And Veronica, I look at you and USAID program to better support countries with this kind of data, because I recall at the time the Minister of Finance really wanted comparable data, with respect to this. Also to mention, I look at my colleagues from Tanzania, they have a strong regional bloc, SADC. Must we pay like the numbers that Elizabeth mentioned for in terms of regulatory, must the Tanzanians, the Ugandans, the Kenyans, must they take manufacturers through the same processes? Can we not use one platform? Because at the end of the day, the prices will be transferred to the beneficiary, to the patient, if we're able to leverage each other's strengths in terms of regulatory harmonization now, you know, and the emerging ACTA policy that's just been launched, which makes Africa a common regional market. There are again huge potentials to be leveraged from there. And lastly, to say that public financing of services is not necessarily and must not, in a UHC paradigm, is not public delivery of services. Whilst public financing is a sine qua non, it is to buy those services from wherever quality is assured and whoever is best available to deliver that. That is the paradigm of UHC. So as a strategic purchaser, you want to buy from wherever, be it public or private. And to me, that's a sine qua non. That's the way we can increase beneficiary choice. That's the way we can reduce transaction costs. And we need to also complement all of this with technology. That's one way. Again, I say like what NATO and colleagues are doing. That's one way we can actually go to scale very quickly. Thank you once again, Veronica.
Thank you, Olamide. And I would like to thank all the panelists for a very engaging discussion today, that you brought and shared the best examples and challenges that you are facing currently. So thanks, everybody. I would like to also thank our audiences for submission of the questions and engaging with us in this journey. I would like to invite everyone to our final capstone webinar, which will take place next Wednesday, July 6th. Please join us for defining a pathway to equitable access to quality pharmacy services. Thanks, everybody, and have a wonderful day.
Thank you, Veronica. Thank you, Neto and Olumide. See you next time. Thank you.